In the piece.
In the piece.
I thought we were still in the
No. Let her not get lost. I need someone to explain to her career and she gets on page.
Excuse me.
Yes.
Super, thank you very much. So, 2 people fighting, that's not a team. But 2 people or more with a shared goal, that's a team. So you guys at the ED working together, and maybe not this, because the boy in the yellow shirt, he doesn't have a team, right? And he's not going to be able to help the poor sick child very well. But if he uses the entire team, pilot the guy, he didn't hear properly, so he just told his co-pilots to take off. And since the hierarchy was that big, and in this cockpit you don't speak up to your senior, the first co-pilot, there were 2, said, okay, and the other co-pilot was just silent, and then people died. So what can we learn from this, and to have better clinical outcome? And there are several studies on this. So, and there are a few things that come out when doing these studies that is more important. One is sit in a good way, and the communication is excellent. You're going to be able to coordinate super well, and also the collaboration is going to be super smooth, right? And I'll go through a situational team needs to have a leader. So sometimes when you're in the emergency room and maybe there's a doctor and 2 nurses, usually the doctor is the leader, but sometimes there are 2 doctors and 2 or 3 leaders. It's just going to be messy, right? And this CRM is something that you're going to... so these are communication and situational awareness. And then... okay. Bag and mask. Put it together, have it close to where you resuscitate, not apart and someplace else. The best team are the teams who work together a lot, really. So if possible, I know you guys rotate, but also in Sweden we work with different teams all the time. But if it's possible, the best team is when you train.
So what is...
You first wait and do our work.
Please tell
What do I
me.
say?
This is my only baby.
You first wait. What do I say? Can you please bring for me diazepam here? 50 mil. 50 milligrams of diazepam, please. George, are you listening to me?
But doctor...
I've told you give IV 50 milligrams of diazepam. For you first wait. You first wait.
Is my baby going to be alright?
First wait.
This is my only baby. And I'm the only child in my clan.
Gentlemen, you must listen to us when they are doing that work. I'm doing my part. George, what did you do?
I gave 50 milligrams of diazepam.
50 milligrams of diazepam.
Yes, doctor.
How did you give it?
IV?
IV.
Yes.
Okay. Okay, but you first come and see. Is the baby sleeping? Is the baby sleeping? Okay. Let me check whether I'm still feeling the pulse or what.
Doctor.
I'm not feeling anything. Let me
What has
confirm.
happened?
I'm not feeling it. Ask George, come here. Tell this gentleman that.
Doctor, do you think 50 milligrams is too high?
Oh, I think, okay, I have to cross-check my guidelines, okay?
Doctor, the airway is clear and I put on some oxygen.
Thank you, ma'am. Thank you, ma'am. Okay. Can you please check whether the other secretions clear? Oh, George.
No secretions in the mouth.
Oh, you are very right. Oh, thank you, ma'am. You are very right. It's just 5 milligrams per bottle.
So you say 5 milligrams?
Rectal diazepam.
Okay, 5 milligrams rectal diazepam.
Yes, per bottle. Okay.
What is that you're putting on my baby?
We are
What is that you're pushing?
I've administered 5 milligrams of
Thank you.
diazepam.
Can you please record on the patient's chart?
Okay.
So that you don't forget.
All right, thank you.
Ma'am, how's the airway?
The airway is good, the
Oh,
saturation
perfect.
is
Thank you so
96.
much. How's the breathing, George?
The breathing is not
Oh,
so
but the child is so conversing now, we cannot really assist the breathing well. Okay. Oh, then proceed, how's the saturation? The capillary field? 2 seconds.
So I'm counting the respiratory rates.
Okay. How's it?
So 35 breaths per minute.
Oh, thank you, George. Okay, you can be trying to get a line because we might need it for other investigations. Okay. As our bill wasn't clear because the child was still progressing, but I'm seeing the child is now settling up. Mama, Tata, we are doing all this.
Doctor, I've passed a line and I've collected a sample.
Thank you so much. No, how's our air?
The airway is clear.
You still keeping the
Yeah,
ginger?
he's starting to wake up now.
Okay, perfect. Now that breath, we can now assess the because the child is right and the rest is. How's the central sinuses in it?
No,
Okay. The indrawing, test indrawing.
not so
Oh,
much.
we are somewhere. Mom is doing a good work. You're also doing a good work.
Thank
Okay.
you.
Other
I think we'll come there.
The things that I've written in brackets there are things that are really helpful, but they're not necessary. So what about oxygen?
Come out, release, then again, then you go to the nostrils. If the baby, you assess. If the baby crying, no. So tell the mother. Because there are those cases, they say my baby was changed, my baby was a male, now it is a female. Huh? So you tell her, yeah, mommy, baby is not crying, we are going to resuscitate if the resuscitation area is far from the bed. If you have it next, you can read from the mother. So quickly separate. We said positioning, and we said warm resuscitation, cover the head. If you have the heart, if you don't have, you can put this one over the head. We have 2 sizes of the tongue baby, and make sure the mask covers the nose and the what? And the mouth. Then the technique, you should have it. This one supports the chin, this one lifts the chin, then the 2 fingers make a seal. Doctor mentioned about the firm seal. If you don't make a seal, the chest will not rise. So we give 5 rescue breath, slow rescue breath, that is Etat. Mulago still. Jinja 1, Jinja 2, Jinja 3, Jinja 4, Jinja 5. Then you 5 people holding, even breaking. Yeah? The rest of the bed, just like this. Relax. I'm not resting on the bed. Then 40 times, 40 to 60, reassess. If the baby starts crying, you go to our routine care, skin to skin, monitor the baby with the mother, then you do other things with the mother.
Do those things. Also when you give drugs, there will be syringes, there will be some fluids, so you can actually show how you're giving drug. And you can't prick these kids, the doors, you can't prick them. Alright? So we will give you the scenarios, you do them, and you manage them as if it was in your workplace, and then
of the region to deliver better health services for our people. Excellence, we cannot do everything. We need to build capacity also in the region. And we need to work with all the health players in the region. That's why you will find that we cherish these partnerships. We have the Busoga Health Forum and all these partners to ensure that we do the needful in building capacity for our region. I told you we are discussing issues of land this morning because now we want to stop this business of referring everybody to Kampala, especially those who need specialized services. Oncology services, sometimes blood transfusion, sometimes kidney, dialysis, and so on, cardiac services, all the specialized services. Many times we are referring, but time has come for us to build capacity in the regions so that we handle most of these cases within the region. Those who go to Mulago and Kampala in general should be those really who need very, very specialized care. The rest we must handle here. Our people are poor, we cannot afford to be sending all of them to Kampala. They spend a lot. So we are already in that business. You are aware that you are here for Etat, emergency, triage, assessment, and treatment. So when you talk of emergency, you are talking about conditions which require what? Immediate attention, or else life is lost. So when we talk of emergencies, there are so many conditions, as you will be told in this training. I think 5 days you'll be here. So you will go through a lot of these emergency situations, and many of them require urgent action. So if you are going to say, let's refer this emergency to Mulago, how many hours, how many kilometers is Mulago from here? Almost 100 kilometers. So with the traffic jam of Kona and so on. So we lose a lot of people along the way because emergencies must be promptly addressed. For example, someone is bleeding and needs the urgent blood transfusion. Are you going to take this person to Mulago? Will this person reach there? So that's why we are saying, let Busoga have a what? A regional blood bank. Let Busoga have regional services. We now have a 10-bed capacity intensive care unit. So those who need critical care, we're able to manage them here. We just commissioned this recently, and we have some staff that have been trained in critical care. So we are slowly building capacity. We want to bring in dialysis. We want to engage Uganda Cancer Institute to have a cancer screening. It's already actually here. We want to strengthen it. Last week, 2 weeks ago, we were engaging with the Uganda Heart Institute. They want to start doing cardiac surgeries here. I think we'll have the first one either May or June. They will use our facilities, the theater. But of course, with the time, the ultimate goal is to have a regional cardiac center for Busoga here. So all these services require what? Structures which must be built on land. That's why you found the hospital staff trying to put a case that the hospital land should be secured, should be preserved, so that all these services are made available for our people. But staff, I'm glad that you heeded our invitation and you're here. I really want to appreciate all the partners that are supporting us in this. We started this journey, I think, sometime last year, and we are building capacity. You know, we cannot bring all the staff at once. We are doing this in phases. So other districts have been here before. I remember talking to some already earlier this year. So we are in a phased way. We are bringing you on board and building capacity, so that these emergencies we are talking about, the staff, you can be able to handle them where you are. In the Health Center 3 and Health Center 4, there is a lot you can do there in terms of emergency response, so that you can save a life, stabilize before you probably refer to the next level if you cannot provide definitive care there. But first level of care, or the initial care that is needed to save a life, you must be able to provide it wherever you are. That's why we are conscious that as a regional referral hospital, we must build capacity in the lower level structures, in the general hospitals, the Health Center 4, up to the Health Center 3 level, so that you are able to assess these emergencies and offer treatment at that level, or at least stabilize before you transfer. And please, my request is that it is a golden opportunity for you to be here, especially if you're coming from the districts, because there are so many of you that we need to train, but we may not train all the staff there because of resource constraints. So the few who are here, you have been carefully selected because of what you are doing. So while here, give the best of these 5 days, learn as much as possible, ask all the necessary questions, because the experts are here. They will be able to guide and empower you, so that when you go back, the knowledge and skills you have taken from here should translate into improvement in service delivery, and ultimately saving of what? Lives. Lives of our mothers and of our babies. All children must be saved. Plus, of course, all other emergencies. So life matters. We are called by God to serve, and we need to serve when we have the necessary knowledge and skills, so that we don't make mistakes. Sometimes lives are lost because either we don't have the necessary knowledge and skills, or we don't have equipment or facilities that are required. As a Minister of Health, we are doing our best to ensure that the needed structures are available. Recently, you also notice that Minister of Public Service approved new structures for staffing. And with that, we now are going to have doctors even up to the level of Health Centre IV. We now have a whole department, emergency services department in the hospital, in the regional referral hospital. So those efforts, government at a larger level is trying to put to make sure the services are brought closer to the region and even closer to the community. Because now if we can have doctors in a Health Centre IV and other high-level cadres at that level, it means the government is showing commitment in ensuring that really the needed human resource is there. So if we have the human resource, we need to skill them, empower them, we need to provide the needed equipment, and then I think we can offer better quality health services to our people. So I know government is doing its part, the ministry is doing its part. As a regional referral hospital, we are also doing our part. Through the public health department, we shall continue to build capacity, and we will continue to engage all the health partners in this region to ensure that we improve the quality of care and we save more lives. Those of you who saw the results in the recently released Uganda Demographic and Health Survey put us behind as a region in terms of perinatal deaths and maternal deaths. We are not doing well. We are losing so many mothers and so many babies, partly because of the reasons, some of the reasons I've already alluded to. But we can reverse that trend once we do what we are doing and we take it serious and we go out there and commit to the services we want to offer so that we can save those lives. So that's my urge to the staff. 5 days you're here. I'm here with you today. I might check on you again at the end of the 5 days, but I want to request that we give it the maximum interest and attention so that we're fully equipped and we go back ready to serve our population from the districts. It's my hope that we will continue working with these partners to also bring on board the other districts that have not had the chance to be trained. We want to do this for all the districts. And after that, we will now go out also to check. Of course, it doesn't stop here. We will also go out in the field. We'll be following you in the health facilities to see how you are applying this knowledge in your day-to-day work and whether it has impact in terms of the services you're offering. So, so much for that. I want to end by thanking once again all our partners that are making this possible, because for us to come together like this, we require resources. And I want to appreciate UHA, I want to appreciate Busoga Health Forum, World Vision, our Swedish friends here, for giving time and other resources to make sure that this is accomplished. I want to pledge on behalf of Jinja Regional Referral Hospital and on behalf of Minister of Health that we will continue to give the necessary support, and my office is open for any consultations and support. In case you need any support in the course of the training or even thereafter, please feel free to contact me and all other authorities so that you are supported to fully execute your work. And I'm glad that I kept my promise and I've come. Maybe you can appreciate that. Yeah. So as leaders, we need to also to show full commitment in what we do, so that.
They are so supportive.
Yeah. So things will work out. Thank you so much for the support.
Thank you very much.
Please go on with the training. See you later in the week. In the Busoga region, our maternal mortality rate is one of the highest in the country. The picture is not good. The perinatal mortality rate is also quite high. I may not give you figures now, but I know for Jinja Regional Referral Hospital, if you look at the institutional mortality rate, it is over 700 per 100,000 live births. Now that is quite high, given that the nationally now the mortality has come down, so to about 189. So there's a lot for us, work for us to do On average, in Jinja Regional Referral Hospital, we lose about 4 to 6 mothers every month. That comes to about 1 to 2 per week. This is a very high number. For perinatal deaths, it is much higher. We lose so many children. So to bring this down, we have to do quite a lot. One of them is building capacity on our staff to handle these emergencies, especially for children and mothers. We need to build the necessary capacity for the staff. We need also to have the resources, other resources required, such as a regional blood bank, because many of the mothers we lose are because of bleeding. This either postpartum or antepartum bleeding. When sometimes we want to transfuse, you find you have to look for the blood, and the time you spend, running up and down to Nakasero, back and so on, life is being lost. So we want to have a regional blood bank for Busoga here. We want to have other services coming here, and we want to have build capacity, what we are doing now, of our staff. And we're also advocating that we need to recruit more staff in line with the new structures that have been released by government. So once we have all these resources in place, I know that services in this region are going to improve, and many lives are going to be saved. So we are on that mission, and the Regional Referral Hospital is taking lead and working with the district health offices and the health facilities, working with the partners such as Busoga Health Forum, as you have heard, UHA, World Vision, our friends from Sweden. All these partners are willing to work with the Regional Referral Hospital to spearhead the agenda of improving health services delivered in this region, so that we bring down maternal mortality, we bring down child mortality, and we improve the general population health in this region. It is only a healthy population that can be productive. So for us to be economically viable, the population must be healthy, and that's our mission. We're going to work with these partners and the districts to ensure that these services, health services in this region, are improved, and our people are healthy and therefore economically productive.
The baby is still fluffy and screaming. So after that, the airway is clear. Yeah, the airway is clear. As you look into the mouth, the airway is clear. So I go ahead to assess for breathing. There are no chest movements, no here.
We have a suggestion, keep the baby warm. What is a good way to keep the baby warm?
Huh?
Walk us through the now we have
Would like to do.
maybe you can
So here's the midwife coming.
So now as the
Yeah, open it, expose the baby's chest. Give first 5 breaths, 2 breaths.
Yeah, there's nothing in the mouth. It's clear. How long did you ventilate?
5 times.
Only 5 times.
At 100 beats per minute.
At 100 beats per minute?
Yes.
So I'm sure this baby, I'm very scared maybe they deteriorate after some minutes. I think I need to give the baby oxygen. So I need to think maybe give the baby at maybe 0.5 liters per minute.
Yes, you're going to oxygen. What next?
I think I can give the mother to the baby together.
What if our baby relapses again? Before giving.
I'm a pediatrician and an associate professor of global health at Karolinska in Sweden. And I'm here as one of the collaborators on a course, a one-week course, in emergency triage assessment and treatment. We're doing this course within a partnership that we have between Stockholm and Jinja, with Jinja Regional Referral as the focal point, and Busoga Health Forum, which is a local NGO. And the purpose of this training is to increase the quality of care for severely sick children. So we know that the majority of, there is a lot of deaths taking place within the first 24 hours in hospitals. And there's like 80% of the deaths are caused by similar conditions. So now, Etat, which is the abbreviation then for Emergency Triage Assessment and Treatment, it's a structured way where teamwork is important to manage these children for early identification of severe illness and making a plan to stabilize these children and hopefully make them survive. So the training was initially developed by WHO and was updated by WHO, but then it has been developed into more detail by different pediatric associations, including in Uganda. And just recently in December, the Ministry of Health in Uganda released their facilitators guideline for national training on Etat. So we have actually, within the partnership we've actually done this. This is the third training. So we started a little bit more than a year ago with the first training. But now, with the release of the Ministry of Health guidelines, we can do it exactly according to their developed schedule. So this time is the first time that we actually have someone from the ministry who is also taking part in the course as a national trainer. And then we have a team of regional trainers, which are health care staff working in Jinja Regional Referral that have been trained through the partnership between Sweden and Jinja to actually become facilitators of this course. So I guess with the long-term plan we have with this, and we're hoping that we can now, with this training, of course, we have a representation from many different facilities within Busoga. And of course, the first objective or aim is for them to now bring this new knowledge back to their facilities and then improve the quality of care where they work. Secondly, we hope to identify more people that can be key or persons or focal persons in these different facilities that can continue to work together as a network on improving the quality of care for severely sick kids. And eventually we also want to build capacity with more facilitators to repeat this training, because this cannot be one-off. It needs to be repeated. You need to constantly train, and also the trained people need to be mentored. And that this is now, we have received support from Uganda Health activity, USAID, and also from World Vision, and they're coming in to support this training as well. And of course with that we can also increase capacity and take this further. Well, I need to give different answers to that question, because it depends on, I guess, which partner you're asking. So if you ask the ministry, I suppose everyone who's working in a health facility with kids should be trained. If you're asking the funding partners, I guess, they are probably agree with the ministry. Within the partnership between Jinja and Stockholm, our plan was to first, starting with the Jinja Regional Referral Hospital, and then we would continue with the district hospitals, going to the health facility force, and then continue further down, so to say, in the health system. We don't have a specific, for the partnership, we don't have a specific target of health workers, but of course we would like to have this implemented in as many facilities as possible. I think before we started these training activities and the partnership, actually, we did a readiness assessment, including all facilities in the Busoga region that are admitting children. So all public facilities and private not-for-profit. And what we found was that, well, one, there is a challenge with resources. But two, we could also clarify that with training, health workers will both manage children in a better way. They will have a higher knowledge of what to do with a severely sick child, and they will also feel more motivated and actually also have a higher work satisfaction if they have done this training and they feel that they are ready to handle these severely sick children. Target and work around the issue of increasing skills, and I think specifically focusing on the ABC, like working in a structured way. With the resources, that's another challenge. And of course, unless we work with both at the same time, we can't expect to reach a very, very good outcome. So this is also something that needs to be recognized and targeted in coming interventions. You asked me about the main reasons that children do die. So, well, we do know that of course, neonatal circumstances around the newborn, like prematurity, asphyxia, that is lack of oxygen at the time of birth, they are common contributors to child death in low-income countries. For the older children, the ones that are older than 1 month of age, we still struggle with common illnesses such as malaria, pneumonia, and diarrhea. So infectious diseases that, as a fact, can be easily treated if you just recognize them early and you start interventions to handle them. We know that due to delays, both from the parents' side, so they may not understand their child is sick and they may have issues to actually reach a facility, and that can cause the child to develop more severe illness along the way, maybe even the referral way. And once they reach, there may be issues in the triaging of children to actually identify them early and to see, according to this structure, airway, breathing, circulation, what do we need to do first to stabilize these children? So now in this course, we're working with evidence-based guidelines that are packaged in a very straightforward way, so that any level of health facility or health worker can easily adapt these guidelines and apply them in the workplace to achieve a better quality of care. In this training, we work with, as I mentioned, we work with short presentations, but a lot of interactive sessions. So skills training and scenario training. So you get a practical hands-on training where we work with mannequins to pretend we're working on a real case. We're covering how to triage severely sick children, that is how to sort them as they arrive to the facility, how to identify the ones that need to be attended to early. Then we're working also in this course in a structured way, like what to do if a child has collapsed, there's no signs of life. Then you need to do resuscitation interventions. Now, if the child has got signs of life, you start with the A, the airway, the B, the breathing, the C, the circulation, to handle those issues as you go. And we're coming into some specific conditions, such as pneumonia, but the target is really to be able to work on a symptoms-based manner to intervene with issues causing life-threatening symptoms.
I'm Dorothy Akongo, the Head of Research and Advocacy from Busoga Health Forum. Today we are here at Civil Service College, training health workers in emergency care assessment and triage. This is aimed at improving the capacity of health workers in handling emergencies within their health facilities. And today we are partnering with our Swedish partners, Swedish Children's Hospital, the Uganda Health Activity and World Vision, to have more numbers of health workers trained in Etat to see that the rates of children dying within their 1,000 days of life, like the infant mortality is reduced, because currently the infant mortality in Busoga is higher than the national mortality. It's at 53 per 1,000 live birth compared to 43 for the national mortality. So we are really working towards reducing that mortality rate to see that the children born within the region, like a few of them are dying compared to what it is right now. So we are working with different partners to see that this comes to pass. So some of the topics that are being covered, we have nutrition and hypocalcemia, and we also look at the teamwork, because we realize that these emergencies are not handled by one person. So we look at different teams working together to achieve the same goal.
Amanya gange nze ali nabisere nkolera Nalfenya dwaliro ly'abaana liri wansi wa Jinja General Referral Hospital. Training eno njiraba ng'egenda tugasa nnyo ng'abasawo okusinziira tutandise olunaku olwaleero, kubanga bintu bingi bye tubanguseemu okuva bye twatandise okumakya paka kaakano. Ebimu tubadde nga twabivaako ng'abasawo nga tetukyabikola, ebirala tubadde tetubimanyi, naye kati okusinza kusomesa okutuweereddwa tulina ebintu bingi ebipya bye tufunye okuva ku makya. So okusinziira ku ekyo ndaba nti ennaku 5 we zinaggweerako nga batusomesa tugenda kuba tubanguse nnyo, era tugenda gasa nnyo ebifo byaffe ffenna buli wamu gye twavudde. Abalwadde baffe bagenda kuyambibwa nnyo, okugeza tumbanguddwa nnyo mu ngeri y'okukwatamu abalwadde abajjidde mu mbeera kwegamba ng'omuntu ali bubi nnyo. Twongedde okutegeera nti omuntu ono mbaawula ntya, ono yeetaaga obuyambi obw'amangu ne yeetaaga okukolebwako oluvannyuma. Era we mba mwawuddemu oyo yeetaaga obuyambi obw'amangu, ate era waliwo abasukuluma ku balala, okugeza abamu babeera nga tebassa bulungi, oluusi alina ekimutuze, oluusi alina obulwadde obukireese okuba nga tassa bulungi, oluusi abalala talina musaayi. Kati byonna okuva ku makya we twatandikire newankubadde lunaku lwe lusoose, tuyiza engeri y'okubakwatamu, engeri y'obapositioningamu singa tuba tutte mu ruumu zaffe eza emergency, tumwebasa tutya ku kitanda, ki kye tusooka okukola, ki ekiddako, tulyoke tate tugende ku bujjanjabi obulala. Era mu kyo tumaze okulaba nti singa tubikwata bulungi nga bye batusomesezza, abantu ababadde bafiira mu ssaawa eno esooka nga balindirira mu layini bagenda kukendeera, kubanga tulabye nti mu malwaliro abantu bangi babadde bafiira mu layini nga balinda olw'okuba nga baba tetutegedde engeri gye tubaawulamu bulungi. Naye tulabye nti singa tunaabiteeka mu nkola, abalwadde bagenda kukendeera abafiira mu layini. Ekirala era tulabye nti guno omulimu gw'okwawulamu abalwadde bano abajja si gwaffe ffeka abasawo, naye tulina ogukwatira wamu n'abantu abalala be tukola nagana mu ddwaliro, tugeze nga batula ku tebo zaffe abalikodinga abalwadde, basikaali bennyininyini ku geeti. Tulabye nti nabo tusobola obbayikwipinga, obbasomesa ki kye tukola, nabo ne batuyambako nti omulwadde bw'atuuka ku geeti wali asikaali asobola otegeera nti omulwadde ono si waakulagirira agenda kusimba mu layini, wabula waakutwala direct ku emergency olw'embeera gy'aba akoze eki, gy'abeera amulabyemu. Ne bw'abeera kirina tukiyize nti ffe ng'abasawo tulina obbabangulako bwe tuyize leero, nti nabo bennyininyini kirina ono bw'alaba omulwadde ono ng'ali mu mbeera tugeza tassa bulungi oba alina engeri gy'assaamu etali nnuŋŋaamu ng'abalwadde abalala, tamulinza mulagirira nti nno maama tuula wali mu layini, wabula amutwala mu emergency, ate nga ne mu emergency gy'amutuusiza naffe abasawo abaliyo tuba nga tumaze okutegeera ekikokola ki ekyokukola. Era twongedde n'okutegeera nti si bonna abalwadde betulaba abazze nga bali bubi bonna beetaaga oxygen, kubanga oluusi tugamba oxygen malwaliro nti taliimu. Abalwadde bwe batyo ne bafa nga tulowooza nti nno buli azze nga tassa bulungi yeetaaga oxygen. Naye okusinziira ku ekyo tufunye leero, si buli mulwadde ajja nga tassa bulungi yeetaaga oxygen. Waliwo emitendera egisooka bukolebwako omulwadde oyo, ate ne tulaba nti waba tateredde ku kino kyensoose okukola, ate ne ndyoka ngenda ku step endala ey'okukola ki, okulaba nti muteekako oxygen. Era tulabye nti nti waliwo emitendera gya mirundi 3 bano abajja nga balina obwino obulaga nti bwa emergency, waliwo ate ababaddirira tulaba amalwaliro agamu nga babambaza obukoola obwa red ne yellow ne green okubala nti bawulibwa, naye tulabye nti mu byonna ate naffe abasawo tulina omulimu ogw'okunnyonnyola bano abalinda, kubanga oli ayinza ogamba wange nga mumulese nze yasoose, naye tulabye nti ate era tulina n'omulimu ogw'okunnyonnyola abasawo nti newankubadde wakedde abalwadde bano abakyala abazze oba abantu abakulu nti wadde wakedde, naye okusinziira ku bubonero omuntu ono bw'ayina tagenda kusimba layini, alina okuyitawo, oba okusinziira ono bw'ayina ono yalina okusooka ku layini, oba okusinziira ono bw'ayina ono yasobola okulinda, netusobola netusooka netujjanja abantu bonna abalala netumala netukola tutya naawe netuleka tukwatako. So ebintu bingi byetuyize mu lunaku luno olusooka, newankubadde nga lwelusooka tumanya nti wetunaamalirako ennaku zaffe 5 mutuufu tugenda kuba tuli wala nnyo era tugenda gasiza ddala amaliriro gaffe mu Uganda.
Ninze Waiswa Athanasius nga nkolera Kamuli Mission Hospital gye beteruwaga. Training eno y'ennaku 5 ya mugaso ino gye tuli era tujja otuuka mu twabona nti tweta nti twali tusomye ebintu bino aye ate ebintu bijja bikyuka, kusoma kujja kukyuka, research erikyuka leero niido, so tujja obona nga ebyetaagisa bino ebyaka twetaaga eno etegekeibwa aba Busoga Health Forum, era tubeebaza ino nti kino ekintu ekikoleibwa leero wamona ku 5 kijje mmaiso oba kituuke ne kubasaba abandi abatasoboire kuba wano, era nga ntusa n'omulanga nti abasawo abasinga be represented abarepresentinze amalwaliro gaibwe oba districts de wendiri nti baireyo basobola otuusa obubaka buno oba okusoma kuno emisomo gino ku bantu abandi tusobola okutambuza obusawo nga tiimu ya mugaso ino enaku naweera ya 5 kiraba tugasibwa ino. Abaana abazifiire babeere bali kufa ino research bwekoba nga bali kuzaalibwa ino mu leba yebazaalibwa, so kibeire nti ino nga resuscitation oba obuyambi obwetaaga obwamangu ino ng'omwana yakazaalibwa tubeire nga tulina amagezi matonotono, so kati gano amagezi gebatuwaire batwekwipinze bongaire okutuzimba ate bulungi ino nti kino kijja kendeeza abaana ababeire kibafa ino nga bamaze ozaalibwa.
Gange nze Mbwali Lydia Magumba ndi muzaalisa kolera ku ddwaliro einene ery'omu Luuka District Kiyunga Health Centre IV. Eruuka ekifasite gyenviiriiremu neringa eidwaliro einene ery'omu district, so nti efuna referrals okuva mu facilities edo wansi Health Centre IIIs and IIs kubanga nawalinga equipped wasobola ofunaku ku service ed'abaana abato. Mu training eno gyetuyidyemu we are grateful nti tuli mu bantu beba selectinze okwidda traininga mu training eno nti tuli ba ambassadors ababanaife abasigaireyo wansi. Kiyunga as a facility erina rates nnyingi ed'abaana ababeire bafa nga bakazaalibwa, ti lwakubanga nti ffenna we tukyetaaga, aye lwakubanga sometimes wabaawo knowledge gap. Suubira n'ensonga lwaki tuyidde wano tujje tu bridging knowledge gap eri ne banaife abasigaireyo. Training eno ya mugaso ino gye tuli era tuyidde nti we tunaava wano tujja creating out change. Bintu bingi ino so far bye twakabonaku n'ebindi bye tusuubira obona nti I've even realized nsuubira eri abaana betu declaring nti bafa nga bakalina kufa. N'ekindi nsuubira okwidda kwaife wano kwidda akendeezaako obwana bwe tuweereza ku hospital ennene, kubanga w'olingiriramu obona nga kyetuleetera obasindikira tusobola ffenna okimplementinga ewaife twabanga tureducinze ku okufiira mu njira omwo wagati. N'ekindi abantu baife awulira nti okujja ejjinja obanga omuwaire kibonerezo, sometimes atuukayo yeekyawa yalumuka ne mu idwaliro. So okwidda kwaife wano kakasa bwe tuneeyirayo kwidda akola kyamaanyi okusavinga abaana bano ababeire bafa nga bazaalibwa oba abafa mu kiseera ekyo eky'omwaka omulala okuyika wansi. Tuli basanyufu ino wairenga waliyo gaps kugeza ng'ebyuma biki ebyo aye tuikiriza nti abatuleese wano ndowooza baidda kuyamba ku disitulikiti yaife okutwekwipinga n'ebintu ebyetaagisa okutuyambako okudelivaringa services. Mu iddwaliro lyaife ery'Ekiyunga on average katukobe nti nsuubira mu mwezi tubaire tufuna abaana nga 4 abafa nga bazaalibwa ng'otoireku abafiirawo nsaawa esooka ng'ogeiseeku n'ababa bafiire like a week back, then n'ogeitaku ni bano ababa bali awo admitted mu kasenga ak'abaana era bona baamala sometimes baabitirayo. So nsuubira we tunaava mu training eno tusuubira okukendeeza ku muwendo gw'abaana abafa nga baakazaalibwa. Tiddaako nti kuva ku 4 kuyira ku 2 wabula neeyama nti we tunaava wano tuyidda kuyiza ku 0 kubanga mbutuufu it is unfortunate nti omukazi abise mu mikono gyo aye yaafiirwa omwana. Nsuubiza nti we tunaava wano tuyidde akendeeza ku muwendo gw'abaana abafa nga bazaalibwa.